Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam, and this is Cardiology Seminars brought to you by Triple N Media YouTube channel, where we have more than 200 cardiology lectures, and we welcome you to watch these lectures. And we also kindly request you to please do subscribe to our YouTube channel so we can notify you of the next video. Before we begin with the feature presentation, I would like to invite you to get a free copy of my Cardiology Rotations Manual, which consists of more than 165 pages of chock-full information as how to maximize your cardiology experience while you're rotating through the cardiology floors. So let us begin with the main feature presentation, which is hypertensive emergencies and treatment. According to the American Heart Association, the normal blood pressure is supposed to be systolic less than 120 and diastolic less than 180. Anytime the blood pressure is between 130 and 139 and the diastolic between 80 and 89, it is considered to be stage 1 hypertension. Now, if you go to hypertensive crisis, the blood pressure is generally greater than 180 millimeters of mercury, and the diastolic being greater than 120. However, these numbers are not actually etched in stone as far as hypertensive crises are concerned, and I'm going to explain to you as we go along. The definition of a hypertensive emergencies and their clinical presentation. A hypertensive emergency is the association of significantly elevated blood pressure, not necessarily maximum blood pressure, but substantially elevated blood pressure with H mod, hypertension mediated organ damage. So there's got to be two components for someone to have an hypertensive crisis. One is they have substantially elevated blood pressure, and the second point is there is some evidence of hypertension mediated organ damage, and this could be in the eyes, in the retina, or it could be in the brain in the form of hemorrhage or stroke. It could be in the heart causing ischemic chest pain, acute coronary syndrome, or even myocardial infarction. It could be associated with large arteries, with peripheral arterial disease like carotid artery or peripheral arterial disease in the legs, or it could be associated with significant renal failure. This situation requires a rapid diagnostic workup and immediate treatment with intravenous medications to bring down the blood pressure, and the rapidity with which we bring down the blood pressure depends upon the underlying H mod, hypertension mediated organ damage, which is a key factor in managing hypertensive crisis, which we will emphasize again and again during this presentation. The clinical presentation is determined by, of course, the organ that is affected, like visual disturbances or flashes in the eyes, or along with elevated blood pressure. So the symptoms can be related to headaches or visual disturbances involving the central nervous system. It could be chest pain related to ischemic heart disease, dyspnea related to acute left ventricular failure or pulmonary edema, neurological symptoms, dizziness, which can be related to severe hypertension and also related to reduced cerebral perfusion, and other unspecified symptoms. It could be bleeding from the nose, this could be anxiety, could be loss of consciousness. Whenever we are evaluating a patient with an hypertensive crisis, history is extremely important. What is their pre-existing situation? Do they have heart disease? Do they have kidney problem? Do they have vascular problems? Is there a history of stroke? Does a patient have history of hypertension? What kind of hypertension does this patient have? What medications the patient is getting? Is a patient sticking to the medications? Is a concomitant use of blood pressure elevating drugs like non-steroidal anti-inflammatory agents, steroids, immunosuppressants, sympathomimetic drugs, cocaine, anticholinergic therapy. Hence, documentation of their entire medication is of great significance in managing patients with hypertensive crisis. Clinical examination, obviously their blood pressure will be more than 140 millimeters of mercury systolic. Course, a fundus examination may reveal some evidence of a hemorrhage, exudates, AV nicking, or papillary edema. Cardiac findings may reveal evidence of a prominent apical impulse, suggestive of left ventricular hypertrophy. There could be a gallop, and there could be rouse and pulmonary congestion. Renal, of course, we may see reduced urine output with pre-renal isotemia. They may also have GI symptoms like nausea, vomiting, weakness, fatigue, dizziness. Some of the lab tests we would like to focus on include hemoglobin to look for any evidence of bleeding, platelet counts for bleeding, creatinine for kidney function, electrolytes, lactic dehydrogenase, haptoglobulin, and of course urine for protein and sediments, and EKG for any evidence of ischemia or infarction, and also cardiac arrhythmias. Troponin may help us to identify any evidence of acute coronary syndrome. A chest X-ray may show cardiomegaly, pulmonary congestion, or evidence of infection. And transthoracic echocardiogram is very vital to look at the left ventricular size, left ventricular function, left ventricular contractility, wall motion abnormalities, any evidence of valvular or heart disease, and also look for left ventricular hypertrophy and evidence of diastolic dysfunction. A CT MRI will be an integral part of managing patients with the hypertensive crisis while we bring their blood pressure down, and it may show evidence of ischemic stroke or hemorrhage. CT angiography may be useful in diagnosing acute aortic dissection. Acute aortic dissection is a life-threatening cardiac emergency, and in most cases, following CT angiography, something definitive may have to be done in terms of a surgical intervention. It carries a pretty high mortality. Here are some of the findings related to hypertensive crisis involving retinopathy. There could be the pruning of the arterial system. There could be hemorrhages and fluffy infiltrates. There could be papillary edema and also AV nicking. So these are some of the findings that we may find if you are good at checking the eyes. That may give you an insight as to how long did this patient have hypertension, and does this patient have retinal complications. The antihypertensive treatment is predominantly determined by the type of the organ damage. As I told you in the beginning, the treatment or management of hypertension depends upon 1, the elevated blood pressure, and number 2, the target organ that is involved. If you have a malignant hypertension, severe hypertension like 200/120 with advanced bilateral retinopathy, then we are going to be treating this differently compared to a hypertensive encephalopathy with severe hypertension, lethargy, seizures, cortical blindness, and coma in some cases. Third kind is the hypertensive thrombotic microangiopathy, which is associated with hemolysis, thrombocytopenia in the absence of causes, and improvement with blood pressure lowering regimen. There are a few other conditions that may be associated with the hypertensive crisis, such as the dissecting aortic aneurysm, which I already talked to you about, which requires a CT angiography to diagnose the presence of aortic dissection. And of course, acute left ventricular failure with pulmonary edema, acute myocardial ischemia or infarction. Eclampsia is another condition that is associated with the hypertensive crisis, and we'll talk about that in a minute. Of course, acute renal failure and microangiopathic hemolytic anemia, which I just mentioned. How quickly do we need to bring the blood pressure down? We talked about the 2 criteria: elevated blood pressure associated with target organ damage or hypertension mediated organ damage, HMOD. The next question is, how quickly do we need to bring the blood pressure down in order to, 1, protect the blood pressure, prevent the complications, and also make sure we prevent hypotension. If a patient has an acute pulmonary edema or an aortic dissection, we need to bring the blood pressure down now. Not 1 hour from now, not 4 hours from now, but right now, as soon as we see the patient. And we'll talk about what drugs can reduce the blood pressure immediately, I mean within minutes. Whereas if the blood pressure, if it is not exceeding 220 over 120 and is generally well tolerated in acute ischemic stroke for certain period of time, that means we have time to bring the blood pressure down, but it is not a super emergency as in a patient with acute pulmonary edema or aortic dissection for that matter. Those patients who have elevated hypertension without any target organ damage are not considered hypertensive emergencies, and they can be treated with oral medications. I may take an issue with this one. If the blood pressure is 240 over 140, we would like to bring it down at least 25% over a period of several hours with intravenous or oral medications. Because we don't want them to get into a state of organ damage. Like they may be stable when they come in, but later on they could develop ischemic stroke, or they could develop acute pulmonary edema, or their kidney function can get worse. So we not only do we assess the patients when we see them in the emergency room, but also anticipate what could go wrong while we are trying to bring their blood pressure down, so that we keep track of these H-mod conditions. The therapeutic goal is, of course, controlling the blood pressure in a safe period of time based on the underlying target organ damage, and limit further hypertensive damage. At the same time, avoid hypotension and any complications related to that. Unfortunately, there are no significant randomized trial data as far as what is the target blood pressure and how quickly we need to bring it down and what's the outcome based on those things. But nonetheless, all we have expert opinions which we'll talk about in a couple of minutes. While we are dealing with an hypertensive crisis patient, we also need to be concerned about other differential diagnoses. Not everything that is high blood pressure and some organ damage is hypertensive crisis. The hypertension may be secondary to an underlying kidney problem. Somebody who has chronic kidney disease, who is volume overloaded, who is having symptoms of heart failure, and the blood pressure is up because of volume overload, salt excess, and a number of other things, including skipping medications. So we need to be able to differentiate these things, which may not be easy in an acute situation, but once we get the blood pressure under control, look at the target organs, and then see which came first. Did the hypertension come first, or did the conditions that are listed here come first and caused secondary hypertension? Of course, left ventricular failure can also lead to hypertension or hypotension, uremia, cerebrovascular accidents, subarachnoid hemorrhage, brain tumor, encephalitis, hypercalcemia, acute anxiety, hyperventilation syndrome. A whole host of these things can mimic hypertensive crisis. That is why we have to make sure we have a correlation between accelerated hypertension with hypertension-mediated organ damage. Let's talk about some specific conditions. I've been talking about hypertension-mediated organ damage. So let's look at each one of these situations and see how quickly we need to bring their blood pressure down, what medications are available, and later on we're going to look at what exact dosages we can use as a starting dose and how often do we titrate those. Let's talk about malignant hypertension with or without acute renal failure. We can bring their blood pressure down over a period of several hours. Bring their blood pressure down mean by 20% mean cyst pressure. The medications that would be beneficial in these patients would include labetalol, which is an alpha-1 blocker, and beta-1 and beta-2 blocker. It can be given intravenously, it can be given orally. We'll talk about the dosages. If that doesn't work, we can also either use nicardipine along with that, and an alternative would be nipride or nitroprusside. Hypertensive encephalopathy. People having dizziness, weakness, lethargy, then we need to bring their blood pressure down immediately. This is a hypertensive crisis. 20% to 25% down immediately. For that, we're going to need intravenous drugs like nicardipine, nitroprusside, while using intravenous labetalol. Acute ischemic stroke and systolic blood pressure greater than 220 millimeters of mercury. There you have little time to bring the blood pressure down, and also you don't need to bring it down by 25% like in a patient with hypertensive encephalopathy, but a 15% reduction over a period of 1 hour may be acceptable, and we can use the same drugs to accomplish the target point. Acute ischemic stroke with indications of thrombolytic therapy and a systolic blood pressure greater than 185. We can bring the blood pressure down within an hour to a mean minus 15% arterial blood pressure, and of course we're going to use the same class of drugs. Now let's look at acute hemorrhagic stroke and a systolic blood pressure greater than 180. Hemorrhagic stroke now, that was the previous one was the ischemic stroke, and this is a hemorrhagic stroke. Now we need to bring the blood pressure down immediately. Because of the hemorrhage, we need to drop the blood pressure, reduce the bleeding, and hopefully minimize the CNS complications. Again, the same drugs are available, urapidil instead of nitride here. Acute coronary event. Of course, if we are dealing with acute coronary events such as acute coronary syndrome, elevated troponins, abnormal EKGs, or acute pulmonary edema, then we need to bring the blood pressure down immediately. We need to bring the blood pressure to less than 140 millimeters of mercury. So this is one situation where we really need to bring the blood pressure down as quickly as possible, and the best drug would be nitroglycerin because it increases venodilatation, it brings down the arterial pressure, it reduces left ventricular end diastolic volume, it reduces pulmonary congestion, and it also helps to bring the blood pressure down. Similarly, we can use labetalol. The alternative would be urapidil. Acute cardiogenic and pulmonary edema, which is similar to an acute coronary syndrome, is sort of a worst scenario of an acute coronary syndrome, and we use the same drugs. My first drug of choice would be nitroglycerin. Being a cardiologist, I would use that one, and along with some loop diuretics, so we can reduce the salt intake, increase the venous capacitance, reduce venous return, reduce pulmonary congestion, and thus bring down the blood pressure and also reduce pulmonary edema. Aortic dissection. The name of the game is to keep the blood pressure below 120 millimeters of mercury and keep the heart rate below 60. So we're going to need a combination of esmolol to bring down the heart rate down, which can be given intravenously, along with nitroprusside or nitroglycerin or nicardipine. Any one of these drugs given intravenously as an infusion would be ideal while we are getting the CT angiography, how significant aortic dissection is and what we need to do next. Eclampsia and severe preeclampsia. As a matter of fact, eclampsia is noted in 5 to 10% of the pregnancies. I was quite surprised to look at the data. We need to bring their blood pressure down immediately. Systolic blood pressure to less than 160, so we don't need to drop it to 120, and the diastolic below 105. Labetalol would be fine, nicardipine would be fine, and of course magnesium sulfate has been the long-standing treatment for hypertension in patients with eclampsia. And here are the dosages of these drugs, especially if you're in the intensive care unit and you are writing the orders, as you know, what dose do you start with? Nitroprusside 0.25 to 10 micrograms per kg per minute, begins to act within a minute or two. We need to be concerned about thiocyanate and cyanide poisoning. Nitroglycerin 5 to 10 micrograms per minute. It's not based on weight, works within 1 to 5 minutes and can be titrated every 3 to 5 minutes. And of course, flushing, headache, methemoglobin. Nicardipine 5 to 15 milligrams per hour. Nicardipine is quite an expensive drug, so we need to be concerned about if we have a better alternative like nitroglycerin or nitroprusside, 5 to 10 minutes. And hydralazine is a drug we need to be concerned if you're dealing with an acute coronary syndrome. Hydralazine has been found to increase myocardial ischemia and precipitate myocardial infarction. So if you have any changes on the electrocardiogram, if the cardiac enzymes are abnormal, or if the patient has pulmonary congestion or any evidence of myocardial ischemia, I would avoid using hydralazine. We have much better intravenous infusions which can be titrated minute by minute than giving hydralazine, which acts for 3 to 8 hours and you can't reverse once you have given the medication. Hydralazine causes reflex tachycardia, which is not beneficial to patients with acute coronary syndrome. Enalapril is quite useful. It can be given orally or as an intravenous 1.25 milligrams or 5 milligrams every 6 hours. The duration is 6 hours. And it takes 20 to 30 minutes to act. It will not be the first drug of choice in dealing with hypertensive crisis. The drugs of choice in dealing with hypertensive crisis would be labetalol, number one, cardiac issues, nitroglycerin, and you want to bring down the blood pressure quickly. The third option would be nitride or nitroprusside. Here we also have phenoldiazepam, 0.1 to 0.3 micrograms per kg per minute. Again, it can be titrated. Again, all these drugs cause flushing, headache due to vasodilatation. Labetalol is an alpha plus beta blocker. The dose is 20 to 80 milligram IV bolus every 10 minutes and 2 minutes IV infusion. So labetalol is very useful in reducing the heart rate, reducing the blood pressure because it acts on the alpha receptors and it acts fairly well. The duration of action is 3 to 6 hours. But if you need any immediate action, you need to combine that with another infusion drug like nitroglycerin or nitroprusside. One thing you need to be concerned about using any beta blocker is hypotension, heart block, and worsening of acute pulmonary edema. Esmolol is a beta-1 selective beta blocker. It's like 200 to 500 micrograms per kg per minute for 4 minutes, and then 150 to 300 micrograms per minute. Again, we need to watch for hypotension. Phentolamine is a alpha-1 blocker, which is given 5 to 15 milligrams IV. One titrate onset is 1 to 3 minutes, and the duration is 3 to 10 minutes. Of course, it causes tachycardia and flushing like most other drugs. Anyway, we also need to be concerned about which drug do we need and what is the underlying condition. For example, if we are dealing with a cardiac patient in pulmonary edema, the problem is volume overload or left heart failure, elevated end diastolic pressure, elevated end diastolic volume, pulmonary congestion. So you need a drug that reduces venous return. In those patients, nitroglycerin would be the first drug of choice because it works on the venous system much more so it does on the arterial system. It will help us to reduce the venous return, reduce the left ventricular end diastolic volume, reduce the pulmonary congestion, and help with the symptoms while we regulate their blood pressure with maybe a beta blocker, something like that. And all the rest of them have arterial action predominantly, and the most significant of which is hydralazine. But again, I would be cautious about using hydralazine in patients with ischemic heart disease, especially if they have an acute ongoing ischemia. Minoxidil is not necessarily used so often, but nitroprusside has both arterial and venous dilatation, which is equal, and same thing with alpha blockers. They have both arterial and venous, whereas angiotensin converting enzyme inhibitors, they cause more arterial dilatation versus the venous. Here's another chart just looking at the same data with little different information. You can just go through this, pause the video and look at these. We need to talk about patients in the elderly age group. because these patients may have significant systolic hypertension with not much diastolic hypertension. They could be running around with 220, 240 systolic blood pressure, which doesn't mean they necessarily have hypertensive crisis. But if they are having target organ symptoms, then we need to be concerned about. Also, when we treat these patients with medications, we need to understand their blood pressures may come down quite precipitously in the hospital. So we need to be concerned about orthostatic hypotension, or they have diminished baroreceptors, decreased intravascular volume. They could have sensitivity to hypokalemia, polypharmacy, central nervous system changes, and all of these have significant effect on outcomes in the elderly patients. Let's talk about a couple of specific situations, like people who are taking amphetamines or sympathomimetic drugs or on cocaine. They should be treated with benzodiazepines before we get them on antihypertensive treatment. Phentolamine, a competitive alpha blocking agent, and clonidine, a centrally acting sympathetic alpha-1 blocking agent, is useful if additional blood pressure lowering is required. We can also use nicardipine or nitroprusside as a suitable alternative. Talk about pheochromocytoma. Adrenergic drive associated with pheochromocytoma responds well to phentolamine. Beta blockers should only be used once the alpha blockers have been introduced to avoid accelerated hypertension. So first we need to block their alpha receptors, and then we can use the beta blockers. Urapidil and nitroprusside could be used as alternatives. In case of preeclampsia, as I mentioned, we've seen in almost 5 to 8% of the pregnancies around the world. It should be worldwide. It looks like it's missing a couple of letters here. That means we must be getting towards the end of the presentation. Let's keep in mind that these conditions need specific choice of drugs. Ladies and gentlemen, this has been a very quick overview of hypertensive crisis. These cardiology seminars are brought to you by Triple N Media YouTube channel, where we have more than 200 cardiology lectures, and please do subscribe to our YouTube channel and you can watch these for free. If you would like to get a copy of my cardiology rotations manual, which has 165 pages of chock-full information, you can send me an email to drniknikam@gmail.com, and I will be happy to send you a copy of my cardiology rotations manual. This has been a presentation of Triple N Media. I am Dr. Nik Nikam, and thank you so much for watching this presentation, and please do subscribe to our YouTube channel. I will see you in the next video.